Thank you very much, and pleasure to be here. We have been discussing with the media at length in the last 1 week because we launched the new global report to report of the world situation, as you see there, the burden, the progress, the challenges, and so on. And so we have been dealing, as I say, with media intensively. So any question you have, you please just don't hesitate. You stop me and you say, I don't understand, so that we clarify immediately. These are the figures that the whole world has heard about, as I say, a week ago. And you can quote them. So now, this doesn't seem to work, though. So maybe just the pointer. Doesn't seem to work.
3 o'clock is forward, 9 o'clock is back.
Yeah, that's what I was doing. There we go. Now it works. So I will do, and this presentation, by the way, I just did this morning to the members of parliament. There are about a dozen members of parliament here that have been convened by the union to be briefed about the situation in the world and about what needs to be done. Coming from the UK, from South Africa, actually the minister is here, Kenya, Tanzania, Australia, and France, and so on. So this is what I will do, basics. You probably don't need the basics. If you need the basics, you tell me now. There are 2 slides that tell you what tuberculosis is. Up to you, really, to tell me if you know it, then the burden, and then the way forward. So these are the basics, one of the oldest diseases in humans. Importantly, we say they are second greatest killer after HIV/AIDS. In reality, the revised estimates now put tuberculosis in terms of number of deaths at the same level as HIV/AIDS, basically. The uncertainty interval are basically overlapping, and you will see what the numbers are. Top killers of women worldwide in terms of those causes of maternal or related to maternal health, call it this way. If untreated, we all know it kills, and it kills about 2/3 in 5 years, according to the old pre-antibiotic statistics. And importantly, 1/3 of the world has what we call latent infection. So you have to understand tuberculosis goes from when you are exposed to someone with tuberculosis and you inhale the bacteria that cause tuberculosis, you enter into a phase called latent infection. 2 billion people are supposedly latently infected. So if we are representative of the world, 1/3 of you will be infected. All right? And we don't know because you never had any symptom, but if I do a skin test or an IGRA, which is a special test, then I may find it positive. So you say, well, what do I need to do? And the answer is, well, if you're not really in any particular risk group, like HIV positive, diabetics, smoker, alcoholic, and so on, then probably you do nothing. If you are, on the other hand, in a risk group that predisposes you to become diseased after infection, then you should probably take prophylaxis. And this is what my colleague Haileyesus Getahun is going to talk about. Tomorrow we will launch a new guideline on the treatment of this latent infection. That's not disease, is latent infection. Once you are latently infected, then you have a chance, which is estimated to be maybe about 5 to 10% during your lifetime, 20 years later, 50 years later, to develop tuberculosis, which is the real disease. You understand that? If you understand that, you understand everything about TB. You don't understand this, you will get confused all the time. You understand it? It's important, this one, latent infection, disease. Okay? All right. So let's go on. Is airborne? You all know that? Yes, please.
I just wanted to find out, when you talk about TB, it's not just lungs, it's all other places in the body as well.
Yeah. The point of entry of the bacillus is almost invariably the lungs. So that's how you get infected. Unless someone, drinks urine of a patient with kidney, it could happen, of a kidney disease. In that case, you have the bacilli there. Or like if you drink milk of a cow that has TB of the breast, for instance. So you can actually get tuberculosis through that way. But it's now very, very rare, and so the vast, 99% of people who get infected through the air. So you breathe the air of someone that has left in your same room, for 1 week, then you have a good chance of inhaling the bacteria, right? And then once it gets into the lungs, that's where our immune system reacts. And so we can contain it, We are capable of containing if our immune system works well. If you are HIV positive, it's another story, because your immune system doesn't work well. And in that case, you are at immediate risk, right? If, on the other hand, your immune system works, then you contain it in the lungs. It may form little granulomas, as we call it, that are microscopic. You do a chest X-ray, you see nothing. Sometimes you see it, little calcified, 1 or 2 or 3 millimeter type of lesion, saying, oh, maybe that is tuberculosis, right? But it heals by itself. In essence, our immune system contains it. And then you become HIV positive 10 years later, then your immune system is not capable of containing it anymore, and that explodes and causes the disease. The disease. That's how it works. And it could go, by the way, to answer your question more directly, once it gets into the lungs, it could disseminate all over the body, and the immune system will contain it. So you may have little granuloma in the kidneys, in the gastrointestinal tract, in the meninges, and then when tuberculosis decides to, go from the phase of latent infection to the phase of disease, then you may get TB meningitis, or you may get TB in the kidneys, without necessarily having the lung disease. But 2/3 of cases, roughly speaking, or more, have lung disease. Many, 1/3 or up to 1/3, depending on the series you look at, may have TB of the kidneys. In fact, the number one outside of the lungs is lymph nodes, the glands. Children oftentimes get disease of the glands, and the glands here, the glands near the heart and the lungs, or the meninges, or the kidneys, or the bones with deformities. People who have TB in the bones, if not diagnosed, then they can have actually collapse of the spine and poof, get paralyzed. And these are things that used to happen more frequently than nowadays, but still is a disease that affects every single organ of the body. I don't remember one organ that has not been reported as the site for tuberculosis. So it's really something that can be everywhere. But the vast majority will have it in the lungs. And the lung tuberculosis is the one that infects others. Because as I said, apart from the jokes, unless you drink the urine of someone with a kidney disease, you will not get TB. It doesn't infect others, right? You have to have it in the lungs. So, which are the most vulnerable? You understand these are the most vulnerable people living in poor, crowded settings, people who are HIV infected, malnourished, that are alcohol abusers, tobacco, meaning smokers, diabetics. 500,000 women die every year, nearly 100,000 kids die every year of tuberculosis. We estimate 10 million orphans, people that have children that have lost their mothers or father or both due to tuberculosis. And then those other populations, high-risk populations, because they infect each other more easily, or they are prone because of stress or malnutrition, meaning migrants, prisoners, minorities, refugees, and so on. Any population that is discriminated against, that would be a good idea. Yeah. Can you see it still? Because we have the sun now. Yeah. So a population that are discriminated against. These are the ones marginalized in a society and so on. These are the numbers. 9 million new cases every year estimated, of which you see 500,000 in children and 3 million, more than 3 million in women. So 2/3, roughly speaking, of the cases are in men and 1/3 in women. 1.5 million deaths every year, which means 4,000 every day. So by the time we finish this session, there will be about 200 people that have died of tuberculosis. So just to give you an idea of the seriousness of this disease, which is not often understood because we tolerate it. Allow me to say, imagine if I told you that we have today 4,000 people dying of Ebola. Just think about that. 80,000 children die of TB every year, and more than 500,000 women die of TB every year. And then you see how many are HIV associated. So 1.1 million of the 9 million are associated with HIV, 80% in Africa. And you see how many die of tuberculosis associated with AIDS. And at the bottom you have the statistics regarding the MDR TB. Multidrug resistant tuberculosis is a form of TB that is resistant to the most important antibiotics and drugs that we use for TB, namely isoniazid and rifampicin, INH and rifampicin. You lose those two, then your treatment becomes difficult. And it's called MDR TB. Nearly 500,000 cases every year, probably 200,000 plus people who die of that. Oh, sorry, what did I do? Yeah, let me just, I just put it back there, that's fine. Now, there we go. So, where is the tuberculosis problem the most serious? You see it in basically in Southern Africa, where you have, these are per capita information, so about 1,000 cases per 100,000 people, meaning 1%. 1% of the South African Lesotho Swaziland population gets tuberculosis every year. You see in Northern Europe or in Europe and in Northern America that the rate per capita are in the range, let's say between 2, 3, and 10 or so per 100,000. South Africa, once again, 1,000 per 100,000, okay? So huge numbers, obviously, in that part of the world, but also in good part of Asia, in these countries, in Latin America, you know, Bolivia, Ecuador, Peru, etc. These are per capita. When you put it in terms of fraction of cases that are in different regions of the world, what you see is this figure, this pie. So about 29% are in Africa, about 60% in Asia, between the Western Pacific and the Southeast Asian region, and then the rest distributed between Eastern Mediterranean, Europe, especially Eastern Europe and former Soviet Union, and then Latin America. Cases are coming down. There is slow decline of cases and deaths. You see in terms of cases on top left there, the green curve, peaked around 2000 something, 2002, 2003. After that, started declining, but is declining at 1.5% per year, which is a very slow decline that may require 2 centuries before you have elimination of TB. And you see on the right the number of deaths that is shown in the black curve. So also peaked around 2002, 2003, after which it started the decline, which is good, because once you put together programs, in a way or another, deaths are reduced. It doesn't mean you are, however, cutting the transmission to other people. So you might have transmission that is ongoing, number of deaths comes down, incidence is coming down more slowly because transmission is ongoing. If you treat a person that is going around for 6 months coughing with TB, because TB is a slow disease in many occasions, then this person would have infected everyone, right? But he would not die because at a certain point it gets treated. However, the family is infected, and then they are at risk now to develop TB later on. There is being progress in TB. This is the slide that shows the progress. So in essence, the incidence is falling slowly, as we said. The mortality is falling more quickly than incidence, and it has actually been reduced by 45% since 1990. And as a result of all of this, 37 million lives have been saved, compared to what would have happened without WHO strategies and application of those things. And 61 million patients, for instance, have been cured. So these are no estimates. These are numbers of people that have been counted in the world. But there are big challenges. These are the 5 biggest challenges, I would say, of today. And the number 1 is reaching the missed cases. What do we mean? We mean that, as I told you, we estimate 9 million cases every year. However, we receive reports from countries that are about 6 million. There is a gap of 3 million. Now you can say the estimate is wrong. The estimate is made on mathematical modeling and consideration of all types of information, mortality, prevalence, incidence, and whatever else. So we come up with this number of 9 million. However, the reports are speaking about 6 million. So anytime we go to countries and do special studies, we find the patients. They're not in the system, but we find them. They are either dying at home in very rural areas with little access to care, and they die because of AIDS. You imagine rural Africa, you go there and people die because of AIDS. In reality, they die because of TB, associated perhaps with AIDS. Or they're not in the system because they are in the private sector. So private practitioners take care and simply do not notify. India only 2 years ago made tuberculosis a notifiable disease by law. But if you are a practitioner and you don't have enough time and you want to devote your time to seeing patients and making money if you want, rather than notifying, reporting, then you fall into that problem. So altogether there are about 3 million people of which we do not know anything. How they are treated, how they're diagnosed, or if they are treated and diagnosed. Second big challenge, that of multi-drug resistant TB. Third big challenge, that of TB, HIV, especially in Africa, association between these two epidemics. Fourth big challenge is how to close the gap in terms of financing, because we need more money. I will show you what the slide, what the numbers are in a slide later on. And final point is we have tools, often not adequate. If I want to put it in other words, the current tools allow us really to diagnose TB, to take care of TB, but they're not fast enough oftentimes, so we cannot detect TB early. We don't have treatments that can be given in, say, less than 6 months, or prophylaxis that can be given easily. If I tell you have to take prophylaxis because I found that you are a latent infection person and you might be at risk of developing TB, you have to take at least, daily for 6 months a drug, which after 1 week starts giving you a bit of nausea, a bit of pain. So you stop it because you're perfectly healthy. So you say, well, why should I take this drug? Forget about it. So that is the challenge, how do you do prophylaxis in this fraction of the 2 billion people that are really at risk, the prisoners, the HIV positive, and so on. So that's the challenge. Is very quickly, I mentioned that. So we get notification like that, 6 million now, but we estimate there are 9 million patients in the world, and we are missing 3. Second big challenge, TB HIV, where this is the HIV infection rate in TB cases. So if you go to Africa, you find that at least in this part of Africa, more than 50% of the TB cases are HIV positive. Okay? So in South Africa, it could be 70-80% in some parts. So it means that you have a problem there, because you diagnose TB, you diagnose HIV. And sometimes vice versa. You have a person that doesn't feel well, you do HIV test, HIV positive, then he has TB already. So the association is very strong. And similarly, we have a big problem with multi-drug resistant TB. And there we have the parts of the world which have at least 18%, these are percentages now. So 18%, in fact, in some of these countries is 30% or even 35%, 1/3 of the cases of TB that are multi-drug resistant. So you diagnose TB, you find the patient with TB, you make the diagnosis, but you don't have the drug susceptibility testing that tells you if there is or not resistance, and you treat with normal drugs. It won't work in 1/3 of patients because you need other drugs. It's called MDR-TB, and that requires not 6 months of drugs, but 24 months of drugs, which are more toxic, more expensive, and difficult to procure. That part of the world has the highest percentages. However, when you put together the number of cases, not the percentage now anymore, but where are the majority of these cases of MDR-TB, so you find that nearly 2/3 are in these countries: India, China, Russia, Pakistan, and Ukraine. So they have the burden of multi-drug resistant tuberculosis. In India, you can see it here, and in fact in China we know it even better. In China this is corresponding to about 5.7%, say 5% to make it simple, or 6% of the TB cases are multi-drug resistant. So it sounds okay, 5 is not good, but it's also not too bad, it's not 35%. Nevertheless, the number of patients in China, that is almost 1 million per year, makes it such that 5% of 1 million is something important, and you have to deal with this 50,000-60,000 patients. All right, and this is the response to MDR-TB. I leave it for perhaps the question to go into any detail. Most important points: we estimate 300,000 patients. If everyone with TB had a susceptibility test, not just the confirmation this is TB, but you do the susceptibility test to see if you can treat with the normal drugs, then you would detect 300,000. The problem is not everyone has drug susceptibility testing. Big problem, right? But if you had it, it would be 300,000, and at the moment we detect 136. So which is it's about 1/3, and it's about 40% or so, 35-40% or something like that. But importantly, now we detect more cases of MDR-TB thanks to new diagnostics, rapid diagnostics, and look at how many were put on treatment. 97,000, which is a progress compared to the past, which was last year, for instance, was 70,000 something, but it tells you that there is a gap of about 40,000 between 97 and 136 that are diagnosed with MDR-TB, and there are no drugs there, or the system is not such that you can place them on drugs. So they are queuing. They are on waiting list. Say, oh, I'm sorry, you have TB, and now I detect you have MDR-TB, but go home because I don't have the drugs now, so come back. Come back when we have the drugs. I call you, and this may be I call you 6 months from now, and the patient is dead. So that's an ethical issue now of big importance, because you cannot make a diagnosis without being able to treat the patient. And now we are in a situation where there has been an acceleration of capacity to diagnose and not a corresponding capacity to treat. An acceleration of the treatment has not been parallel to the other one. And also, once you treat, that's what we found in the world. 48% only are cured, so half of them. The other half are not cured. And this is what we presented last week. We can go in detail, but these are the measures to be taken if you want to deal with MDR-TB. You prevent the creation of MDR-TB, which is this one. You prevent the creation by doing good things when you treat normal TB. That's when, if you treat it effectively, you don't create drug resistance. You treat it with one drug, you create drug resistance. So you prevent that. You expand the capacity to diagnose in such a way that you detect them as quickly as possible. You expand the capacity to treat. That's the gap I was talking about. You do infection control so that a patient with MDR-TB cannot transmit to others in the same clinic or in the same hospital ward, which is what happened in South Africa years ago. And finally, you need money and you need commitment. That's what we were insisting with the parliamentarians this morning. Solution, we had a World Health Assembly in May of this year that has passed, ministers of health of the whole world have passed a new strategy that we call the End TB strategy. And the End TB strategy has very ambitious targets. Number one, it wants to have zero death, zero disease and zero suffering by 2035, which implies achieving this level of reduction, which could be a dream, but I will show you a slide where if people did what they have to do and if they put all the resources, then we could achieve that level. So it's 95% reduction in deaths, 90% reduction in incidence compared to 2015. So that's a 2015-2035 strategy. And importantly, no families affected by TB that go into what is called catastrophic expenditure, which is a very clear health economic definition. So you don't want to impoverish further the poorest among the poor. And I was telling parliamentarians this morning that we are fooling ourselves if we believe we can deal with tuberculosis and take care of tuberculosis by imposing cost rather, to patients of drugs, of diagnostics, and of the care. It has to be free, in a way or another, because these are the poorest in the world. So you can't pretend that they will stay there on treatment for 6 months and come every day to when they have no money to buy a ticket for the bus, if they live 20 kilometers away. So this is the strategy. No details at this point. I mean, you'd ask me, but the first one is on care, the second one is on the policies that must be there, and the third one is on research for new tools. And there are 4 principles there: the government stewardship and accountability, the community engagement, the protection of human rights, ethics, and equity, and the adaptation of the strategy to the country needs. I won't talk about this. This is for the low incidence countries. If you have any question, I can tell you, is the adaptation of the global strategy to countries that already are low enough, like Western Europe, North America, for instance. And this is the slide I wanted to come to towards the conclusion. This is what's happening now. It's coming down, incidence of TB, number of cases per year, if you like, 1.5% per year. It could, though, come down at 10% per year. This is exactly what happened in Western Europe and North America 50, 60 years ago. Okay? After World War II, in the 50s, the acceleration of the incidence decline was about 10% per year. Why? Because they had diagnostic capacity, they had treatment capacity, and they had social protection schemes and universal access. So anyone, poorest among the poor, would go to the clinic, be diagnosed, be treated free of charge, right? And their loss of job would be protected against because of social protection mechanisms, and you had this kind of decline. However, this won't be sufficient later on, because the curve normally goes like this, and it tends to then become flat. So what you need here, after 2025, and so basically we're telling researchers, you have about 10, 11 years, please give us a new vaccine or a new prophylaxis or treatment capacity that will be short and will make it more effective. If we have a new tool produced by research that cannot start from 2024, it has to start now, because it takes 10 years before you develop something reasonable, then we could actually push it down at 17% per year, which is the maximum ever seen in humanity among the Eskimos in Alaska and so on. So there was an intensive application of every possible measure that you cannot do on a very wide scale, but you could do it. So in a population like that, the incidence decline was 17%. That we now think that for a large scale you really need something new. It cannot be with the current tools that we have. And that is the financial gap to finish. At the moment, the need globally is estimated to be $8 billion. $8 billion, and $2 billion is what is missing. This $8 billion, rather the $6 billion that are available, pledged today, is a mixture of domestic funding. Roughly 75 to 80% of the funding for TB now comes from domestic sources, meaning Chinese government, Rwandan government put a certain amount of money there that corresponds globally to about 75, 80%. The remaining, say, 20%, this quarter here, which corresponds to 2 billion, has to come from international sources because especially African countries, but also Afghanistan, Cambodia, and so on, depend so much on international funding. They don't have enough, or they don't invest enough, because they have other choices, start to buy missiles, for instance, rather than putting the money into TB. So that's what it is. And then the amount of money needed for research is estimated to be about 2 billion per year. And of this, what is available is this, which is roughly 670 million. So it's about 3/4 that are missing for research. And that's what I asked parliamentarians this morning, so that you can see it for your own use. And with that, I finish. Right? So I hope that this is clear enough. So if you have any question, just ask me, or we go at the end. Up to you. What do you prefer? We go at the end, or?
No, if they have questions now, let's go ahead and ask.
Very good. Yes, please.
Maybe a small question.
She came first.
Okay.
Always women first.
I did an article a while back on TV, and the doctor that I spoke to in South Africa was saying how the adherence levels are very low, and that's one of the biggest problems, and it's just going unreported. So I just wanted to find out from you how big of an issue is it that people, for whatever reason, are not they're not taking the 6 months, and what can be done to
this obviously is one of the biggest problems of TB control. You know, TB care is not like pneumonia that you treat with 7 to 10 days of antibiotics and you forget about it. And people are sick, so they get the antibiotic, they take it because they're sick, they feel sick, and 10 days later they're cured, and end of the story. In the case of TB, it has to last 6 months because these are the characteristics of the bacillus. You have to suppress it for 6 months. After the first 3 or 4 weeks, you kill the vast majority of bacilli, but you have enough there that if you stop after a month or 2 or 3, you relapse. You have, again, the disease. So maintaining people that they are feeling now much better after a month or 2, they feel wonderful. They have recovered, they were not eating, they were sick, tired, and so on. Now they took drugs for a couple of months, they feel perfectly well. And so maintaining them on treatment, making them understand, requires an enormous amount of support, right? And counseling and psychological support, etc., etc. So this is something that has always been a problem in TB control. Globally now, of the cases of normal tuberculosis that treatment lasts 6 months, we have cure rates of 86%, which means that 14% are not cured. And of those, some die, 2-3% die because they have, let's say, extensive and late forms of TB. They come to diagnosis far too late, or they have meningitis, which is very tough to cure. Some disappear from treatment, which is about perhaps globally now 6-7% altogether. So it's not, at the moment, in good programs, a huge problem. Is a problem in some programs that do not have this supportive system. So people are not understanding why they should take drugs, and they abandon, and no one goes back to them. It's much more of a problem in multi-drug resistant TB. That's where it gets complicated. Because there, as I show you, we have 50% cure rate. And of the other 50%, if I recall correctly, 25 to whatever it is, a quarter, something like that, are really defaulters. People that just, at a certain point, disappear from the system. So they don't go back because, number one, the drugs are expensive and they don't have the money. If the program doesn't pay for them, they abandon and they forget about them. Or because they feel bad. These drugs can give you psychotic reaction. They can give you gastrointestinal problems of serious type, liver function that decreases, or gastrointestinal problems such as diarrhea and vomiting. So you have all these kind of symptoms, then you tend to just abandon. And if you don't realize what you are doing, then you are dead, because the next step is then you relapse, and perhaps the disease is more advanced and so on. So you really need a very supportive environment and capacity to sustain these people for 24 months of treatment. Have you ever tried to think 24 months for treatment? It's awful with these drugs. Now the people with HIV, they take it for life, right? But there are probably different ways of supporting them, and probably also the amount of side effects is not as bad as with multi-drug resistant TB drugs. There are psychotic reactions in some of them.
Let's get in one of them, and then I want to get another speaker up here because I want to make sure we have time.
Yep.
In the morning, Lucy mentioned tuberculosis is combining with diabetes and HIV. Maybe there will be an increase of the
TB because of diabetes and so on.
Yeah.
Well, because of HIV, we have seen it all. Because it's 30 years that the two are combined. So in Africa, it peaked already. Now it's coming down. TB HIV in Africa is now coming down because HIV is coming down. And so there is, it's still a big problem, but it's coming down. With diabetes or with tobacco, these associations are now the future of tuberculosis, because diabetes and tobacco use and so on are expanding everywhere. And so we are seeing also epidemic of diabetes, epidemic of for instance, tobacco-related problems. And so if they increase, then tuberculosis is, the chance that tuberculosis increases is also there. The difference with HIV is that HIV increases the risk 30 times or so once you are latently infected to become disease. Diabetes and tobacco, fortunately, is only between 2 and 3 times more than a person that doesn't smoke, for instance. So the what we call the relative risk is much smaller than HIV is 30 times, and this is 2-3 times. However, the population that smoke is much bigger than the population of HIV. So you have I don't know what is the latest statistics about maybe 1 billion people, 2 billion people that smoke. So you have this number, then you have a huge number of candidates to get tuberculosis, even if the relative risk is only 2 or 3 times that of the non-smoker. And same with diabetes.
Yeah.
So yes, it's quite possible.
Your prediction of the growth to 2035
Is taking into consideration that.
Yeah.
Yeah, it's taking into consideration that you should have intervention that act on what is called the social and economic determinants of TB, which includes, for instance, ignorance or no support to stop smoking, or to eat in a regular way. So it includes those kind of measures, which are part of our strategy now. Really advocate for solutions to social determinants and to these other risk factors that come from poverty in general, because people do not fully understand the implications of smoking or drinking or whatever. Alcohol is another risk factor, of course.
All right, let's get Dr. Getahun.
Yeah, we'll do that.
To get started, this is Dr. Haileyesus. He's the coordinator of the TB and HIV and community engagement at the Global TB program for WHO. And can you just be very clear with them in terms of what they can or cannot report, what you're saying?
First of all, thank you. Thank you very much for the opportunity. So what I'm going to present will be, as Mario mentioned earlier, the new guideline, WHO guideline on how to treat latent tuberculosis, which was an area that has been ignored for some time. We will launch this tomorrow in the afternoon, and I think the information should be embargoed until then. I have few copies of the executive summary, which you can take, and tomorrow also we will have the actual guideline in English, French, Spanish, and possibly Russian if it comes tonight. So what I'm going to give you in this 10 minutes presentation, I don't want to bring slides intentionally, because I want this to be much more interactive. So I will give you what is behind this guideline and also our intention how to implement it. But first of all, Mario mentioned what latent infection is, so I'm not going to go there, but these are people once infected by the mycobacteria, which because of the immunity, in majority of cases is basically contained in the body while the bacteria is still viable. But from 5 to 15% of the population will have the risk of developing TB in their lifetime. On average, we say 10%, but it can range between 5 to 15. And also, why are we addressing this latent TB infection? And as I said, this 5 to 15% of the population is also the reservoir for the 9 million TB cases that are happening every year. And especially with the new end TB strategy, which has a very ambitious target of 90% reduction in TB incidence by 2035, we cannot really go anywhere without addressing latent TB, this pool of tuberculosis globally. And also when we really look, although it is estimated the 1/3 of the global population is infected by Mycobacterium tuberculosis, it's not uniform across the regions. And unfortunately, the last estimate was done 15 years ago almost, in 2000, which was published in 2003, which actually estimated 30% of the global population can be infected. But this infection rate of the general population, I'm talking about the general population, varies between 14% in the European region, to 15% in the Americas, to 27% in Eastern Mediterranean region, and 31% in Africa, 32% Western Pacific, and 46% in Southeast Asia. So this is the latest what we have, but since it is quite old, and since 2003, there has been quite developments in terms of scaling up TB treatment, treating, and also in life conditions. This may not be the current situation. So we are now got a recommendation from our strategic advisory group actually to relook and to re-estimate this global burden, and we will embark on that activity very soon. So what is the purpose of this new guidelines? It's just to help countries, programs. We've been actually asking WHO, countries, national programs, and other stakeholders were asking WHO actually to provide clear guidance on how to deal with this latent tuberculosis infection. And also now we have identified around 30 countries for elimination of TB as part of our implementation strategy for the new anti-TB strategy. And also in those, the LTBI guideline will serve as a backbone for those interventions really too, because in these low incidence countries, much of the TB is coming from the high risk group. So WHO has to give clear guidance how to deal with TB in these high risk groups. And also the guidelines are providing a very new way of approach, and as a public health approach. It's although I think one thing which I would like to emphasize is whenever we are treating latent TB, the primary benefit should be for the individual. We don't have any much evidence that it will have a public health or it will have a community level impact, but the focus should be for the individual benefit. However, the approach should follow basic public health approaches. So these guidelines also give what those basic public health approach for the implementation of this guideline will be. So what are the target audience? We are not recommending this guideline all over the world for all countries, although in principle it could be applicable. We are focusing on those countries with low incidence of TB, which we defined less than 100 per 100,000, and are also rich in terms of resources, either in upper middle income or in resource-rich countries. And this is because managing latent latent TB entails quite a lot of resource mobilization. And also, if the TB is high, the active TB, the primary focus should be more on addressing the active TB in those countries, like in Africa. So we have identified actually 113 countries who will be targeted, who basically should implement these guidelines. So the guideline has key recommendations. One recommendation is actually to identify the risk groups that would benefit from latent TB management. And when we say management, the management should include from diagnosis, treatment, and follow-up as well. And follow-up during the treatment as well as after the stoppage of the treatment, because we have to still monitor and evaluate patients for development of active disease after they stopped taking the latent TB. So what are the risk groups we identified? As a strong recommendation, we call it strong, which means the evidence is overwhelming and it has to be implemented in those countries where it is recommended, is basically for people living with HIV and child and adult contacts. When we say contacts, those people who have exposure with a person with pulmonary tuberculosis. And also we recommend it for people having what we call silicosis. Silicosis is mostly dealing with miners and mining industry. And then there are also clinical conditions, mostly in hospitals, like people having end-stage renal problem or renal failure and who are taking hemodialysis. And also those patients who are preparing for transplantation. It could be organ transplantation or hematologic transplantation, from the bone marrow for blood cancers. And also those patients, again, mostly hospitalized, who are taking what we call anti-tumor necrosis factor treatment. These are mostly diseases related to the immune system, and this drug is given to treat those illnesses, and then their susceptibility for tuberculosis will be high. So basically these are the risk groups where this new guideline strongly recommend the treatment of latent TB. And there are second class of risk factors, risk groups, where the latent TB diagnosis and treatment is conditionally recommended. When we say conditional recommendation, it has to be based on the local context and also the decision of the local programs as well as the need for the intervention. And these risk groups include prisoners and also migrants, mostly from high burden countries into low incident states, and also homeless persons, drug users, as well as healthcare workers. Depending on the local situation and their exposure, these are groups where WHO now recommends LTBI should be considered. In the previous, it should be done. Here, it should be considered. And also for the lack of evidence and also for the challenge of operational implementation, we are not at this point in time recommending LTBI treatment either for diabetic patients or alcoholics or smokers. Although we know that all these three groups have actually increased the risk of having TB. So these guidelines do not recommend for lack of clear evidence as well as operational challenges. So basically, I think these are the key recommendations. And in terms of diagnosis, we recommend equally either the tuberculin skin test or the sophisticated interferon gamma release assays. This is a big ELISA-based study and test. So these two tests are the only tests actually that can be done at this point in time to test for LTBI, and we recommend them equally. However, the emphasis on the policy emphasis has been done because of, again, the requirement for intensive resource. The IGRAS, or the interferon gamma release assays, should not replace TST in resource-limited settings and lower middle-income countries, where LTBI is not a priority for HIV positives. For example, in Africa, we are not recommending. We stick to our 2010 recommendation on that. So the other areas are also identified is there is no recommendation how to treat MDR contacts or contacts who have been exposed with a person having MDR, because there is no evidence actually to recommend any treatment. However, the recommendation is for a close clinical monitoring for at least 2 years for development of active TB. So basically, these are the recommendations, and we also identified the research gaps in the document. So all this will be available for you tomorrow. Thank you.
Great. Anybody have questions about that? Everybody's going to read it.
There is a question.
Of the latent TB or of the drugs? What? Right, so everybody get the question. If you're feeling fine, your TB is latent, you don't have actual disease, then you take the drugs and...
Yeah, I think this is a good question. Yes, as any drug, there are adverse events or side effects of the treatment that will be used for LTBI, latent TB management. And these side effects, however, are rare to happen. But as part of the management, there should be a close clinical monitoring of the patient. So patients should be told that if they have detected any early signs of the side effect, which mostly is affecting the liver, it could be change in color of eyes or abdominal pain, they have to stop and they have to reach to their doctors. But the actual figure for occurrence is very low.
Can you clarify for me, and Diana, you can go ahead and come up, and we're going to introduce you in a minute. Can you have latent multi-drug resistant TB, and if so, is that diagnosable, and would you then be treated with the correct drugs?
In principle, there should be no difference whether the bacteria is drug resistant or not. So there should be no difference. But as I said earlier, we have no recommendation to treat drug resistant contacts because there is no evidence to support it. However, we recommend patients should be followed up for 2 years.
Okay.
Thank you.
Very good, thank you. So we're going to follow up, and Diana, again, I'm going to ask you to clarify for the group exactly what they can and can't report. Is it Weil? Weil. Diana Weil is the coordinator for policy, strategy, and innovations for the Global TB program at the World Health Organization. She's got 20 years of experience in global public health policy. She joined WHO in 1991 and has collaborated with the Ministries of Health in Latin America, Asia, Africa, to analyze how different development policies actually affect health. She's also an expert on international financing for TB control and many other aspects of controlling this disease. Diana, thanks so much.
Hi. Thanks so much, and it's great to be here with all of you. What I am not, and I want to say it up front, is I'm not a physician, and I'm not a clinical trial expert. So I'm presenting on behalf of colleagues in my team that have worked on the clinical side of this guidance. What I'm presenting to you today is on guidance that's embargoed till tomorrow. It's the second new guidance that we're producing in 2 years, so one per year, of new drugs for TB, which is an extraordinary experience for those of us that have been in TB. I've been working in TB for 20 years, as has Mario, more than 20 years, and we've basically seen no new novel drugs for TB in those 20 years, and in fact in 40 years. So it's a very exciting time for us to be having new drugs coming off the research pipeline. We're excited that there's a pipeline for new drugs. There aren't enough drugs in that pipeline. We know that there's a limited number of companies, pharmaceutical firms that are working in this area, as well as a limited number of donors, such as the Gates Foundation, NIH, the European Union, and others who are supporting drug research. But it's better than it was in the past, and even though we have a huge gap in the research financing framework, as Mario suggested, there has been progress. So one of these is a new product that was approved by the European Medicines Agency this year. The product is called Delamanid. It's produced by the company Otsuka, which is a Japanese pharmaceutical firm, working with a team of researchers from around the world at clinical trial sites. What's important to say about this new guidance is that it's part of the vision, first of all, of, as Mario had presented, of the NTB strategy and also our current strategy. But we want intensified research and innovation, and part of that is the discovery, development, but also the rapid uptake of new tools. So what we want to be sure is, as soon as a new drug is available, such as when it's been approved by a stringent regulatory authority, and that definition refers to a number of major drug regulatory authorities in the world that meet criteria that WHO has set as stringent, that review drug policy. Once they're approved by those agencies, many countries and many individuals want to know, how do I use that drug? So in the developing world, even before their regulatory agencies have begun to review it, they're saying to the World Health Organization, what can we do? Should we use this drug? And so WHO needs to provide guidance not to the regulatory authorities. Our role is not to guide regulatory authorities, but to guide national TB programs and how they should use the drug. So that's what we're going to talk to you about, this guidance today. So the reason this drug is a drug that's dedicated to the treatment of drug-resistant TB. So as Mario has well reflected to you and others, drug resistance is a major threat in the world today for TB care and control. We estimate that about half a million people have drug-resistant TB or have developed it just this year alone. And these are people that have resistance to 2 drugs. As you've heard, the drugs are toxic, they're complex, it's lengthy, expensive to treat, and the treatment success rates are not great. So any new drugs that can actually contribute to improving those treatment regimens is an asset. So what I'm talking to you about today is a drug that isn't the magic bullet. It's not one drug that you provide to everybody and MDR is cured, but it can improve the effectiveness of the treatments, the number of drugs they're providing today. So since the treatment success rates are low, we want a drug that can improve treatment success. And in addition, some of those, as you've heard, some of those people with MDR have resistance to additional classes of drugs. So in some cases, they have resistance to aminoglycosides and caprimycin, which are 2 other major drugs. If they have resistance to all 4 of those, it leaves them as XDR patients. They have very few treatment options. So what do we do? What is Delamanid offering us? It's a novel drug that has finished phase 2B trials, which means it hasn't passed through all the phases that clinical trials go through, or drugs go through in clinical trials, but it's passed through 2 of those major phases. Because the world is so worried about antibiotics today and the dearth of antibiotics, regulatory agencies are now offering conditional approval processes that allow drugs that have only gone partially through the clinical trial process phases to be considered for use on a conditional basis. And this is how this drug Delamanid was approved by the European Medicines agency. It's currently about to go under review with the Food and Drug Administration, and it's also gone through a review with the Japanese Pharmaceutical Regulatory Agency. So it's a novel drug. As I said, it was produced by Otsuka, and it was approved in April 2014 for use in MDR treatment. However, it was a conditional approval, which means it has a limited period of approval, and there are certain conditions for its use. Now, WHO doesn't automatically take the conditions and recommendations of the European Medicines Association. We actually do our own review of the evidence. So, with evidence provided publicly through published articles from Otsuka, as well as additional data they provided us, we began a review of this drug for WHO guidance. And just to say that a phase 3 trial is now in process of development and rollout. So the assessment of delamitid was done, and I'm not going to go through the steps of that assessment, but it was a full review of the data using consultants and then using an expert group. So what did we do? We said we need to consider this drug because we have an MDR crisis. There are limited therapeutic options, and it's a life-threatening condition. So people need this guidance now, even though we don't have full clinical trial data from a large number of sites and a large number of patients. So one of the other reasons for WHO to issue this guidance is we know in the absence of this guidance, some countries and clinicians might start using this drug improperly, even if we hadn't issued guidance, because the drug is now available through these regulatory agencies. So we said we need to have this expert review. So we had an expert consultation as similar to what Haile described in terms of the review for his guidance that reviewed the evidence, and then based on that, WHO developed its official guidance, which is what we're releasing tomorrow. So the aim of the group was to issue interim guidance, and this is the important thing for WHO. This is not permanent guidance. We're only issuing guidance that has a lifespan for 2 years. And the idea is within the next 2 years, if we have any further safety information on this drug, we will iterate that guidance. We will review it and come up and possibly revise it based on new safety evidence. We will, after that, in 2 years, there may not be any new guidance. So we may just review the evidence and say this interim guidance continues for a few more years till we have phase 3 guidance. So that's what we're processing now. We have a 2-year term with this interim guidance. And this is very similar, I have to say, to the process that we followed a year ago for the other novel drug for MDR, which was released last year by the company Johnson & Johnson and Janssen, specifically the subgroup Janssen. And that drug was called bedaquiline. So you can find that guidance on our website and a note, news from WHO on that product from last year. So in both cases, what we're recommending is that these drugs are to be used on top of optimized WHO recommended therapy for people for whom the current therapy doesn't work. The current regimen is not sufficient to treat their form of disease. So it's additional. It's an additional drug on top of the set of drugs that are available. So this is too detailed for me to go through today because I want you, but you'll see it in the note that we release tomorrow. But the most important thing is this is conditional recommendations based on incomplete data, because it's only a phase 2b trial, and limited data. And some of this data was of relatively low quality because of the small number of patients included in the trials and some of the trial methods. But based on that, we are able to recommend its use, but based on the following 5 conditions. One of them is patient inclusion, so it's only directed for use in a certain group of patients. It should not be used in certain subgroups of patients, and that's where the guidance gives you information on that. We recommend that it's adherence to WHO recommendations when designing MDR regimens. So we do not recommend you just take this drug and give it one-off to patients. As I said, it must be within the guidance for overall MDR treatment, and also within the programmatic framework for the delivery of MDR treatment. As Mario described, it's terribly important how treatment is delivered to patients, particularly who have to have 2 years of therapy. And lastly, we need treatment monitoring. So this means that particularly in this case, I mean, for all MDR patients, you need to have close monitoring. But because this drug is a new drug with insufficient, incomplete evidence available, we have very particular protocols we want to see followed for the monitoring of those patients. And part of that monitoring is pharmacovigilance, which is basically, we all know that in some cases, if you hear that somebody's had a severe adverse reaction, you want that community to the health service. In this case, rather than passively waiting for those announcements to be made, I mean, if health services or health providers or patients come forward with problems, we want a system in place for it to be sure that we can follow every single case and determine if any of those cases had any severe adverse events. And then the last step, which is really important, we don't always put in place, but we want a very certain informed consent process. Now that informed consent process should be what countries have in place, what their own policies are for informed consent. But because this is a new product that hasn't gone through full review, we want to be sure that patients are aware, that might be orally, that might be written, but they need to actively give their informed consent to be given this drug. It will have benefits for many of them. It could be life-saving, but they also need to be aware of the possible harms. And in this case, there aren't severe safety concerns, but it's more the fact that we don't have a lot of safety data. So there may be issues out there that we don't know about for lack of data. So those are the recommendations. I just wanted to say that we're also releasing tomorrow another tool. It's a short toolkit called a WHO Policy Implementation Package, a PIP is what we're calling it for short, which is basically to say that because new drugs, it's a new frontier for TB, and just to say that even in HIV, in most low and middle income countries, most countries have received drugs that have already gone through phase 3 trials. So TB is really a pathfinder in this. They're receiving drugs that are really just rolled off the research pipeline. Because of that, we want countries to really understand what do you have to have in place to consider rolling out these new drugs. So it's not necessarily appropriate for many countries yet who may still be having big problems in getting their drug-resistant TB programs to work. So we give 6 information sheets, 2 to 3 pagers that really give a checklist of what you need to have in place. How do you do an implementation plan? And we're working with a number of different countries such as Vietnam, Indonesia, Kazakhstan, Belarus, and others on how to roll these out, how to use this approach in dealing with the various questions in various countries. And we have a symposium on Friday for those that are here. On October 31st, from 6 p.m. to 8 p.m., we have a detailed symposium where the countries are going to talk about their experiences, and many of the partner agencies that are helping finance the work in these countries to roll out new drugs will be talking about what they're doing. Thank you.
Questions?
Yep.
I think they've kind of answered, but I was going to ask, what steps are you taking to prevent against resistance developing to these new drugs? And that is, I suppose, to evaluate whether the country in question's MDR program
That's right.
is good enough.
So one of those steps is to say the worst scenario would be we get these 2 new drugs out here. They're released widely and without controls in the private sector or in the public sector, but without any capacity to use them or training or actually secure drug supply. And you end up immediately developing drug resistance to these drugs, and then we have to wait another decade for new drugs to be available, or even more. And the pharmaceutical industry might say, we just lost those drugs. Why would we invest again? We have no return on our investment, and we get bad credibility for the drugs being misused. So the idea is a country has to take seriously with its regulatory agency and the Ministry of Health to say, okay, who should this be used by initially? And so it's really saying, with antibiotics, we did a pretty poor job in many cases of regulating it. The drugs went out to many people. People overused antibiotics extensively. So in this case, you want to roll it out to those that we know can use it well. So that means one of the things we have in our packet is don't roll it out to the private sector immediately. Now, private sector can bring big access to a large number of patients, but you want to be sure that they can provide quality care. So only the private sector that might be accredited or might be licensed that you have as the public sector, can review what are their credentials, are they ready, are they trained, do they have a link to the program, will they report their cases to us? So those are the kinds of questions we have in this packet. Think consciously, if you're the national program, Ministry of Health, who you want to collaborate with in rolling this out. And if you're the regulatory agency, the first thing you want to do is you don't want billboards of this new drug going up all around the city and everybody demanding it as the next general broadband antibiotic that I take for my cold, which we know in many cases it could be misused in that case. We already have an experience with bedaquiline in Eastern Europe where there is, because it's gone through private pharmaceutical company licensing, there has been experience where it's been widely available. You can go onto websites and find bedaquiline advertised. Now, whether it's truly bedaquiline or a false product, we don't know, but it's possible people are getting access to drug that both isn't quality and that we don't know how it's going to be delivered. So those are the key things. And really thinking about the monitoring and evaluation system you have in place on following up on that drug. Now, some advocates may say, well, that's too restrictive. We have people dying today. But we have to sort of think about the people that need help today and the people that will need, the thousands that will need it for the decades to come. So we have to protect the drug and ensure the most rapid expansion of access. But we can all be honest about this. For example, bedaquiline, it's not a fast rollout. It's taking time. Most countries, it's taking a lot of time to prepare. And the regulatory agencies also are being careful because they know that this is a drug that hasn't gone through full clinical trials. So they want to be sure that they're rolling it out with care as well. So you had it.
How soon is this drug going to be available? Is it available? People are taking it? What stage is it?
All right, so Otsuka, in the case of bedaquiline, the drug that came out last year, that Janssen & Johnson created a relationship with the Global Drug Facility, which is the Stop TB Partnership's Global Drug Facility, which enables access to a large number of countries, ministries of health, through ministries of health, to procure the drug. And the Global Fund is providing financing for countries that meet WHO's criteria to receive that. With that financing, people can purchase through the Global Drug Facility. So that's been set up. In this case, and again, this is under embargo, that Otsuka is under discussions now with the Global Drug Facility on that. It's not arranged yet, but they're considering that. They already have plans because of the EMA for its use in Europe. But in the rest of the world, the considerations are that it would be tiered pricing similar to bedaquiline, 3-tiered pricing. I didn't talk to you about that before, that they've offered 3 tiers, one for high-income countries, one for moderate-income countries, and for low-income countries. The prices are still quite substantial for bedaquiline, and for delamanid, we don't know what those pricing tiers are going to be yet. They haven't told us what those prices will be. The big question is that affordable? Even with the tiers for the low-income countries, is it affordable? And that's something we need to evaluate with our partners and with countries as we see, can they procure it? Will the donors give them the money to procure it? Yeah.
Will it be easier to identify and detect the delamanid based on the experience of bedaquiline? And will those countries automatically get access to they've already met the criteria to subject?
Not automatically, because first, WHO is not providing sort of we're not a regulatory authority to say, yes, you get access, you don't, but we can give them the advice. At this point, it's hard to say. First off, one of the most important things I should have said up front is that we don't have information about the use of these 2 drugs together, and that's one of our cautionary tales. There are some studies that the National Institutes of Health are doing now on the use of bedaquiline and delamanid together on top of MDR treatment. We don't know the results of those trials yet, so our recommendation says we can't provide a recommendation yet on how or if to use these drugs together. But yes, certainly we want similar steps to be in place. And so for countries that are beginning to develop their pharmacovigilance capacity, that are beginning to do a rollout plan and have an implementation plan, that they do have a good foundation for considering use of delamanid. And we also have an operational guide that we'll be releasing on the website tomorrow when we release this, that gives more guidance on what choices countries and programs and clinicians might make between these two products, because they have different groups they're directed for and different groups that they're restricted in use for. So you can look at that guidance tomorrow. So thank you. Yeah.
In India, our official guidance is we can't introduce any drug without phase 3 trial. So is this drug, this Getahun, going to be introduced in India?
In India, so the question is in the phase 3 trials, and this is where my colleague, Dr. Lienhardt, who's worked on this guidance in detail, could tell you whether India is part of the planned phase 3 trial. I think it may be part of that planned phase 3 trial. In the case of bedaquiline is not being introduced except for compassionate use in India yet. Also because there's an interest in India to do their own trials on the use there. So India is one case where there is a lot of interest in doing their own studies. South Africa is one of the countries that's been the most advanced, also because it has a lot of clinical trial sites. And most drug companies that release a new drug, they're particularly concerned in ensuring that there's access to the drug in the countries that helped do the trials. Naturally, those should be some of the first countries they consider. So South Africa's had a strong compassionate use program for bedaquiline, and now is beginning to scale up its use. It's one of the few countries that's really beginning to broaden its use to many more sites. So Delaminate, I think we have to sort of say, watch this space. Let's see what happens in the next few months. But in the meantime, people can begin to look at the clinical guidance that we're providing and and begin to think about the rollout plans. And then we'll hear more about pricing and more about regulatory review processes in more countries.
Very good.
Thank you.
So much,
Thank you.
Diana. Terrific job.